now like to welcome to the stage Secretary Julia Houston and Dr. Rob Todd. And as I do that, if I need to remind you all of Julia's remarkable accomplishments.
No, you don't.
So I just watched Julia lead new member orientation as secretary of club. And I thought to myself, there are a few members who've lent in harder to the Atlanta Rotary Club than you have. I think this is the third consecutive program that you're actively involved in, maybe 4 this year. You've introduced 2 new members. You are a very, very well-prepared member of our membership committee. So thank you for leading by example. For those of you who don't know Julia, she serves as Chief Marketing and Strategy Officer for Equifax, whose CEO, Mark Begor, we heard from last week. Julia tells me that Mark sent out to his 15,000 employees an email on Sunday telling them all about the Rotary Club and what we do. So talk about impact. She lives our motto of service above self every day. She currently serves as board chair for the not-for-profit organization CHRIS 180, a behavioral health organization committed to addressing the social determinants of health to help individuals, children, and adults, per the program we had earlier this year. And so I want to thank you for everything you do, and we're looking forward to our conversation. So welcome to you both.
I have to clarify. I think that was an old bio, because I used to serve as board chair. So thanks, Adrian, for that introduction. And I'm so honored today to get to have the opportunity to have this fireside chat with my good friend, Dr. Rob Todd. You no doubt read his really impressive bio in the email advertising the program, but I do want to provide just a few highlights to set the context. Rob has been I'm going to call you Rob because that's what I call you, but obviously the respectful term is Dr. Todd, has been the chief of acute care surgery at Grady Health System, also known as head of trauma. That's how we refer to it, though it means much more than that, which you'll tell us about. But he's been there since 2019. He's served at some of the leading trauma institutions in the country, Bellevue in New York, Methodist in Baylor in Houston, and now Grady. We're really lucky to have him in Atlanta. He's a brilliant doctor and has had a huge impact on the delivery of services, and I know you're all really going to enjoy hearing from him. So, Rob, thanks for being with us. I want to divide our conversation today in 2 parts. First, I want to talk about Grady, and then and its role in the community, as Ken and Adrian already mentioned. And then I want to talk about your job as a trauma surgeon and what we as business leaders can learn from you. But I want to start out by asking you a question, just a personal question. So everything I know about an ER, I learned on TV. So maybe just give us a little sense of what it's really like and how it differs from what I grew up seeing on ER.
Well, first, thanks, Julia, and thanks to Rotary Atlanta for having me here today. It really is an honor to represent myself and also Grady from that perspective. I wish it were that salacious and interesting, but it's really not that exciting. The TV shows always portray it to be this glamorous kind of high-risk, high-stakes game, which it is. It just doesn't have all the bells and whistles that you see on television. And so I can't find myself watching medical shows on TV because it's not realistic. It's probably the same thing for folks in the audience who are lawyers, judges, things like that. It just doesn't resonate when you know what really happened. So it's just not that exciting.
Well, and it is that exciting. But so starting out, I want to talk about Grady's role in the community, as we've already recognized. We know that Grady is really a cornerstone of healthcare in Atlanta. It plays a critical role in providing trauma and emergency services. And it's also a safety net hospital, providing care to some of Atlanta's most vulnerable citizens. So as we think about Grady as sort of a world-class trauma center, it's the busiest level 1 trauma center in the state of Georgia, what distinguishes Grady's trauma care from other hospitals?
Well, I think you kind of alluded to it. Atlanta only has one level 1 fully verified adult trauma center, and that is Grady. Whenever Wellstar closed AMC, that led us to a little bit of a challenge. And we're not only the busiest in Georgia, we are currently the busiest trauma center in the United States. And that's a little known fact. I think a lot of that came about whenever AMC did close, but we were kind of going there anyway, just with our sheer volumes. What that means is at Grady, we see about 15,000 what we call trauma activations. And an activation is the most critically or injured trauma patient when they come in. And out of that, about 2/3, about 10,000 get admitted to the hospital every year on the trauma services at Grady. To put that in perspective, the American College of Surgeons is the governing body that verifies trauma centers nationally. And they require that you admit 1,200 patients annually. And at Grady, if you think about it, we're admitting almost 8 times that volume annually compared to our counterparts around the country. So it really is astronomical that we're able to do that, number one, successfully, and do it well, I would say, providing excellent care of our patients. When you look at what that looks like from a Grady perspective, we've partnered with many of you in this room and your corporations. We really could not survive with our corporate partners, our community partners, and also goes on to our governmental partners. I think when AMC closed, we had severe partnerships from both counties, DeKalb and Fulton, but also from the governor's office. And over the last 2 years, Grady has built over 175 beds within the walls of the hospital. You wouldn't see it from the outside, but on the inside, we have almost 200 more beds. That puts us over 900 beds. That's a very large hospital system and a very large hospital. When you look at that individually from a trauma perspective, 52 of those beds are dedicated towards our trauma population. And we routinely fill those 52 beds in other beds. Other beds went to med-surg beds. Probably one of the most unique things from a trauma care perspective that Grady did do is we built a rehab hospital within the hospital. So there's a 24-bed rehab unit in Grady now. And I will tell you, the victims of trauma, of stroke, of heart attacks, once their care is done in the hospital, it's not over at that point in time. And I'm sure many in the audience have had loved ones who have experienced those situations. And they do need an acute rehab hospital. Unfortunately, in the state of Georgia, and this isn't just Georgia, it's nationally, but in the state of Georgia, rehabilitation beds are a precious commodity. We just don't have enough statewide. So for us to have those 24 beds internally, it allows us to really take care of some of our unfunded patients, high-risk population who otherwise would never have access to that care. Those are kind of some of the clinical things that we've done in addition to facilities, in addition to personnel and things of that nature.
So put that in perspective. So 52 beds out of 900, how does that compare to other trauma centers as a percentage of total beds?
Yeah, and that's just 52 for trauma ICU. Overall, we have about 150, 140 ICU beds, but the overall number is probably consistent. That number of beds for trauma is a very high proportion. Yeah. Okay. And all of that has to deal with the volume.
Yeah, and you referenced just then, the patients who are, in underserved or that can only come to Grady. And so talk a little bit more about that. What are you doing to address health disparities in Atlanta and to ensure access to quality care for all of Atlanta's residents?
Yeah, I think health equity is a fundamental right, I would say. And if you look at the simplistic form of health equity, it's fair and just opportunity to be healthy. And when I say that out loud, that sounds incredibly simple. I will tell you that is incredibly complex in the environment we live in to provide affordable, high-quality care for all. That's very challenging. Several years ago, the Grady leadership and the board had the foresight to create the Office of Health Equity. Dr. Yolanda Wimberly is the Chief Health Equity Officer at Grady. And when Yolanda first rolled things out, she really did a lot of what she called listening tours. She talked to probably some of you in the audience, a lot of folks around the hospital, and really got an idea of where are our gaps and what are the opportunities. And what we realized, there are a lot of gaps when it comes to health equity in Atlanta, especially when you take the divide, Highway 20, and go south. I think most of us in the room appreciate that truly is a healthcare desert. We don't have the resources south of the city to provide adequate health care from a hospital perspective, but also a clinic perspective. They started off with a very thoughtful strategic vision, and the first thing was quality care. It's kind of a no-brainer. The first thing we should always be focusing on is providing quality care for all patients. And that was the number one focus. And I'll kind of talk about each of these a little bit, and please interrupt me if you have further questions. But one of the key things in that was to focus on the social determinants of health. We screen all of our patients. That's food insecurity, housing insecurity, job insecurity. How do we identify those opportunities, then work with those patients to meet them in the middle and help them be successful and have thriving, healthy lives, number one. Number two, we benchmark ourselves. So we say we're going to do X, Y, Z. How are we actually doing if we compare ourselves nationally, and what does that look like? Is it cancer screening? Is it prostate cancer? Is it mammography? Whatnot? How are we actually performing? And the last thing that they're focusing on from the quality care is literacy, healthcare literacy. I think anyone who's not in medicine would appreciate that medicine for any of us is difficult to understand. It is a foreign language. I can tell you as a surgeon, when the medical doctors talk, their language is a foreign language to me. It really is highly complex. And so how do we provide our patients with that understanding of what we're talking about to where they actually can live a healthy lifestyle? That was number one strategic bucket. Number two, they said community engagement. So how do we partner with those of you guys in the room and elsewhere and be better partners? Two big things on that is one, just being out in the community and being involved, healthcare scenes and things like that, fairs, et cetera. The number two thing that they really focus on, which I think is really fascinating, is this concept of workforce and pipeline. How do we actually have a workforce that looks like our citizens we're taking care of? Because I can tell you it doesn't always look like that when you look at who's taking care of the hospital. And so they developed a program called TELP, and I know some of you in the room have children who have gone through this program, but it's the Teen Experience and Leadership Program. And this past summer was the third summer. They bring teen students in, and they actually spend time at the hospital. They learn what we do, what different parts of the hospital do. And Lawrence Blair is our manager of injury prevention and outreach. And Lawrence always said the hospital is a microcosm of the world when it comes to opportunities and jobs. And it really is. Anything you can think of, you can do in a healthcare setting. And so it gives those kids exposure to a lot of those opportunities. And a lot of the kids come from underserved neighborhoods. So being in healthcare has never been in their brain as a possibility. So we actually hopefully open their eyes to that being a possibility to give them a thriving lifestyle. And then have our workforce mirror our patient population in the future. Number three was really looking at cultural competency. And that was kind of looking internally. How do we look as an institution? What does our workforce look like? What do they experience from a physical standpoint, but also a mental standpoint, and how do we care for them? And then fourth one, that was advocacy and social justice. And the biggest bucket of that really was looking at financial distress from healthcare. Healthcare can be devastating financially for many of our patients, for many of our families, but when you're under-resourced, don't have insurance, healthcare really can devastate your entire livelihood and your family's life moving forward. So how do you tackle that? So I think those are kind of some of the big bucket, 30,000-foot view. I would say just on the physical space, when you think about it, we are trying to focus on where we put our health centers and our community clinics. I'm proud to say today is actually the opening of the Lee and White Clinic, which is in the West End. It's our 8th community health clinic out there. We just opened Cascade. There's several more on the horizon. But both those are south of 20 in the southwest part of town. And it's where some of our greatest need is. And so how do we actually meet our patients and those in need in their neighborhoods so that they can actually get access to quality health care? The last thing I'll just mention on that, and then I'll stop talking, but is the freestanding emergency center. I'm sure everybody in the room has heard about this, but Grady is going to develop a freestanding emergency center, which will be in Union City. It's going to open in 2026 and start providing access to those really, critical needs in the acute setting that right now those patients don't have access to.
So obviously you're doing that's a huge list of things that you're doing to address the health equity. How, to play on that, what support can the business community and the people in this room provide to Grady as you move forward with those initiatives?
Well, I'm looking at Jocelyn, but no. I mean, in all seriousness on that, I think number one is how do you ensure you have a healthy workforce? So it's easy for us to think grand, but if we're thinking about all of your individual corporations, companies, whoever you work for, how do you ensure they have access to health equity and a healthy workforce? Be it with your insurance plans, your leave, time for leave, things of that nature. So I would say almost look internally first and say, how do I do that? Because I would say a healthy workforce is going to be a healthy Atlanta. Yeah. It's good for us, it's good for your business, et cetera. So number one, I'd say that. Number two, and I won't get into politics, but when we look at access and we look at it from a statewide perspective, advocating for access for all to have health care and health care insurance. Mm-hmm. Right now, we're one of the few states left that don't have that. And that is a very contentious, politically driven discussion, so I won't go there, but providing the voice that needs to happen for the state of Georgia is critical. And then lastly, I would just say when you hear the phone ring and you see it's Grady on their line, pick it up. Take a listen. Take a listen to Jocelyn and her team when they're talking from the foundation.
Okay, so now I want to shift gears. and talk about what it's not like, where it's not like what we see on TV, but what what we can learn from you as a trauma surgeon. So you've got to make quick decisions, and you're dealing with patients who are coming in a life-threatening situation without any prior medical history often. And so how do you deal with that pressure, and sort of how do you manage that with your team?
Yeah, it's a great question. It is a high-stress environment and high risk, high reward, but obviously the counter to that is death or destruction or complications or whatnot. I would say first and foremost, it comes outside of that clinical setting. So just basic knowledge, fundamental knowledge. I mean, it sounds really simplistic, but where's your knowledge base on the latest XYZ? That continues for your entire life. So you don't get to go to med school residency and then stop learning. Even myself, being the older person in the room these days, I have to keep up with what's going on currently. Number two in that bucket is we really focus heavily on simulation. We're not going to be able to do it like that every time. So how do we simulate actual environment to what's going on? Liz Benjamin, who's our trauma medical director, has developed what we call a perfused cadaver model. And so the cadavers are actually perfused so that whenever we do perform surgeries on them, they bleed like you or I would in the room. They're as lifelike of a scenario in that environment as you can get without having a real patient there. So actually doing a lot of simulation, both on technical skills, but then also on situations. So if you have a bad outcome or a code, how do you actually simulate that? So when you're in that room the first time, you've done it numerous times before. I would say those two things, they drive two things. They drive muscle memory to where you almost just go into action, you don't have to think twice. And then pattern recognition. There's a lot of times whenever something's in a room and I've been doing this 20 plus years, you can see it coming, even though there's nothing out there telling it, you've just seen it so many times, you know what's gonna happen. Those two things are invaluable. You can't replicate those, unfortunately. That's just time and experience. The third bucket is we do pre-huddles. And so if a patient's coming in who is critical, we meet beforehand to talk about, what all the roles are in the room, so everybody knows exactly what their expectation is and what they're going to do. And if you have some clinical context, maybe what you're thinking you're going to be doing with that patient when they show up. And the last two things I'll say, and I say this all the time to our trainees, it's like, in that environment, I try to slow everything down in my brain. And I say not necessarily what's happening in the scene, it's not going to slow down, but you try to clear everything out, all the noise, all the extraneous information, the phone, et cetera, and just slow things down so you can actually see what's going on. It allows you to have true laser focus on the issue at hand and not worry about the rest of it. The last thing I'll sit there and say is, and I'm sure this is the exact same for everyone in this room, as the team leader, everybody looks to you. You are the quarterback of the team at that point in time in the trauma center, in the operating room. And it's fascinating. If you see that person start to lose their cool, their poise, you can have the most highly functioning team and they fall apart right before your eyes. And I've witnessed it. And so whatever you can do to maintain your poise and cool, you absolutely have to. You don't have the luxury of not doing that.
So I think there are a lot of takeaways for us as leaders from that. Stay educated and make sure that your information is relevant. Practice and prepare, and make sure that you stay cool as a leader or lead the way that you want other people to show up. I do have another thing that's related. I know we're about to open it up for questions, but I do want to ask you about processing failure. Obviously, every case doesn't go the way that you hope it would. And so how do you drive accountability within your team, and how do you and your team work through that failure?
That's a fantastic question. There was a Seth's blog, I don't know if anybody gets Seth's blog, but there's a Seth's blog this week, and it said professionals are consistent and authenticity is for amateurs. And actually I love that in the sense of, like, as a professional, it has to be consistent. So when you think about absolute accountability, there's no other way except absolute accountability. The biggest thing we focus on is psychological safety. So I don't know if anybody's read The Culture Code by Dan Coyle, but he focuses on psychological safety. And that's basically not fearing yourself being harmed, basically. If you can construct psychological safety, you can have honest conversations and dialogues about untoward outcomes. That's probably the most important thing, is having that psychological safety. The other thing I would say is the team matters. I think everybody knows that, but it's getting the wrong people off the bus, the right people on the bus, and then driving the bus. And so if you have the wrong people on the team, it takes one bad apple to really destroy everything. The two things about processing failure I'll say briefly is we do debrief. So after bad outcomes, deaths, in the moment we stop and we actually debrief and say what went well, what didn't go well, and what are the opportunities for improvement? How do we do better next time? We probably should candidly do that all the time. We really do on the most critical patients currently. The more formal thing we have is a weekly meeting called M&M, and it's morbidity and mortality is what the conference is called. And so every week we sit together and we review all untoward complications and deaths and say, how do we do it better? And the way that works is you're sitting in a room with all your colleagues, the trainees, the APPs, everyone's there. Someone else critiques your case. The case is presented, someone discusses your case, discusses what they think you did right, what you did wrong, how you could do it better, and we really focus on what we call OFIs, opportunities for improvement. Where are the opportunities there? And they discuss it, and now I think we're at a point of psychological safety where those in the room whose case it was will actually speak up. And they'll just own it and say, next time I could have done this, or I learned that. By doing that, everyone in that room hears what you did. It allows you to improve your own care, but everyone in that room hopefully doesn't make the same mistake to learn from that mistake. So that's probably the most formalized structure we do.
And I think that learning about failure as an opportunity rather than a setback is just so critical. Don't look for who you can blame, but look for what you can learn. So are you ready for questions?
I think so. We've got a microphone set up. Matt, if you want to come up to the microphone, look at this, a long list of questions. So somebody beat Zach to it first. Go ahead, please. Let's kick it off.
Thank you very much. I want to let you know that years ago my mother was admitted to Grady when she was a resident at Lynbrook here in Atlanta because of a fall she had, and the care that she got was top-notch, and I will always be grateful to Grady for that. You mentioned 15,000 traumas that you bring in, and yet 10,000 residences or overstays for that. When I first heard you say that, I thought, my gosh, where did the 5 go? But then again, I guess a trauma can also be you fall off a bike and you break an arm and you don't need to stay there overnight. Is that correct?
That's exactly right. Those 5,000 are discharges, so they get discharged home without any serious injury, fortunately.
Okay, thank you. Second question, quick. I've been getting to understand the policing alternatives and diversion program here in the city of Atlanta, and a lack of having diversion centers has been a big part of the problem with that being a full success. I understand that there are going to be some diversion centers opening. Does Grady have a relationship with that?
We have relationships with that in certain fashions on our wraparound services. And I won't go into a lot of detail, but we have what's called a hospital-based violence intervention program, and ours is called IVY, Interrupting Violence in Youth and Young Adults. And we focus on those 14 to 34 who are the victims of gun violence. We actually have what we call credible messengers in-house, and they're violence intervention specialists. They all had the lived experience. They were victims of violence. They meet with those individuals the minute they see them in the trauma center when they're able to be seen, and they start working with them, trying to identify what the social determinants are. Intellectually, what we've always done historically is we take care of you clinically, and we put you back in the exact same environment and expect a different outcome. It doesn't resonate. These VIs, they actually spend time to develop relationships, and to your point, we have a lot of community partners, what we call the circle of survival, that they really partner with that we do soft handoffs from these patients. The interesting about that program's been in existence just shy of 2 years now. The average, what we call re-injury rate, is about 20%, and that program, since we started in that population, is less than 2%. And so you're trying to prevent retaliation, number one, and then re-injury, number two. And it is partnerships with community programs that allow us to really, we can't continue to take care of all those patients, obviously, but hand them off to a soft handoff in the community and such things. So,
thank you.
Absolutely.
Matt, go ahead.
Post-COVID, Grady ambulance, I know you're not the only ambulance. There were some long lag times. Has that improved, and what are you doing to improve it?
Yeah, the lag times have gotten much better, and we focus on wall time, how long they're stayed at the hospital, and that's actually shortened significantly from the Grady EMS perspective. Not directly under me, but my exposure and what I hear is we're doing significantly better from the wall times and that lag time.
Sadly, Georgia is now one of many states that has had a mass casualty event at a school, a synagogue, a mosque, a church, a supermarket, a concert, et cetera. And I'm curious how, not just Grady, but other trauma centers, how do you prepare for those? How do you budget for those? What impact does that have on your work and the work of similar institutions?
Well, thank you for that question. I think the first thing is admitting that that's a public health crisis, in all honesty. I mean, gun violence in general is a public health crisis. And we as a nation have to address that and just be honest about it. We don't have to talk about gun control, things of that nature, but gun violence is a problem. And so how do we have responsible, safe gun ownership? That's number one on the educational front. From our perspective, we actually plan and prepare for it every day. One of the, where you call it fortunate or not fortunate, is we do see so much volume that for us, we're getting that kind of volume all the time. It's just not from the same scene. And so that's one unique thing. We kind of say, we almost have a mass casualty, not every day, but pretty frequently, just by the sheer volume across scenes. When you do have from the same scene, it does get more challenging, as we just experienced recently here just north of the city, because they can't all come to one facility. We can handle them mostly at Grady, to be honest. Most facilities can't. And so a large part of that is having the network. We have what's called a RAC, which is a Regional Advisory Committee that works with the trauma centers around the region to make sure that we're all working in construct and sync together, so when those events do occur, everyone's cared for.
Go ahead, Zach.
I have two questions for you, Dr. Todd. The first one is that in the list of the best hospitals in the United States, Mass General is usually at the very top. And it's because I think it has so many departments that are specialty departments that not everybody else has. How does Grady compare to Mass General in the number of specialist departments that we have?
So we have every specialist you actually need. The lone thing we don't do at Grady currently is we don't do pediatrics, but we still do neonatal care and OB-GYN, and we don't do transplant. Beyond that, we pretty much every specialty is. The U.S. News and World Report is really kind of a fascinating report to look at. And I think, a lot of people are seeing a lot of universities are even pulling out at the university level because they question the metrics and how it's utilized. I'd say it's not too far on the healthcare side. If you look at the list of top performing hospitals, none of them are public hospitals. They're all major universities. Having worked in one of those institutions, I can be honest, we had a full-time staff that their entire job was to make sure the numbers were copacetic so that we could be ranked high. And so I think it's a very strategic process, but you won't see public hospitals on those lists ever. It just hadn't happened as of yet. I would argue, and I'm biased, but I would argue we're providing the exact same quality care. We just don't have the same resources as some of those do, probably to navigate the scenes behind it.
Mass General's not a public hospital.
No, it's the Harvard affiliation, primarily Harvard.
Okay, my other question was, in your resume, you graduated from the University of Texas with a degree in business and finance, and then you went to med school. How did you do that? And did you know you were going to be a doctor?
Is doctor squared?
Interesting story, when I did that, I'm 54, so I did that a while back, but when I did that, it wasn't very common, and different institutions I went to apply to, they did not like that. There are certain, Baylor, which oddly enough I ended up working at, I basically almost got kicked out of my interview because how could I actually be serious if I didn't get a science degree? Nowadays, they prefer you to do that because it just means you're more well-rounded. For me personally, I just knew I was interested in the business side of things, the finance side, and wanted to be able to study that and do the science on the side. So it just meant a lot of extra hours and a lot of summers of school is what it really meant.
But you did take the sciences necessary while you were
That's a leading question, or a statement in the form of a question. Thank you, Zach. Predictably unpredictable. So I have one final question, and like Wendy, Texas has lost as Atlanta's gained, right? Simulation and pattern recognition. To pick up on some comments that we had with the panel last week, to what extent are you all leveraging technologies like AI to become smarter at what you do?
AI is on the forefront of healthcare. It really is. And I think in the next several years, we're going to see it really take over to a great extent. From the Grady perspective, we started focusing on how AI interacts with us, more so in the medical record and things of that nature. I think when you do look at medicine, though, you can see a lot of things, radiology, pathology. I hate to tell my colleagues, but they may be out of jobs at some point, because at some point AI will get better at reading images, reading pathology slides, than we will as humans, just from that exact pattern recognition. They can do millions and millions of slides, whereas me as a human, I can't. So I think in the short future, I think it's going to be really interesting to see how AI plays in just certain specialties. I think as a surgeon and a technician, I'm probably still okay. I don't think AI can quite replace me yet. It might in the future, but for now I'm okay. But
it'll be fascinating to see how that unfolds, and perhaps you can come back to our club to talk about that, because it's square in the middle of what we talked about last week. Dr. Todd, you're a gifted technician. You're a great leader. It's a lonely place leading an organization like you lead, as you've said. But we're very, very lucky to have you in our community. I too experienced firsthand ambulance to rehabilitation, a family member deal with trauma through your organization. You all do God's work, and I hope that you'll take that message back to your team. You've given us not just business principles, but a clear call to action on how we can partner with you in order to continue to make Grady the crown jewel of our city. Next week, we're going to be continuing our theme on healthcare. We're going to have Dr. Mandy Cohen come and talk to us about the Center for Disease Control. And so it'll be interesting to see what she has to say. So I want to thank you for your time. Julia, what an engaging conversation. Who thought it was more than just George Clooney rescuing, the situation? So thank you very much for your time and effort. Please, the call to action on season of service, let us know what you're doing. Howell, happy birthday. And with that, this meeting's adjourned.